Thank you for coming. I am Jocelyn Kessler. I've been with the ASPCA for almost 7 years now. And prior to that, I was not in animal welfare. I actually come from a long history of retail and sales and marketing operations. So when Bonnie, if any of you caught one of Bonnie's sessions yesterday, she mentioned being in retail. You will hear some semi-familiar things throughout our presentation today. Because Bonnie and I seem to have twin paths a little bit in that we were in client service prior to coming to animal welfare. So with that, I'm going to let Dr. Brown introduce herself.
Hi all, I'm Carolyn Brown. I'm a veterinarian and the Senior Medical Director for Community Medicine at the ASPCA. I've been a veterinarian for over 30 years, and back when I became a veterinarian, we all did this because we really didn't want to work with people. We liked animals. And so during this presentation, you'll see how times have changed in our profession.
So now that you know who we are, and Dr. Brown mentioned she's a Senior Medical Director. I'm the Senior Director of Operations for Community Medicine for the ASPCA, and we have mobile and stationary spay, neuter, and primary pet care clinics in New York and Los Angeles, and soon to be Miami. That was weird sound. And soon to be Miami, and so we are sort of partners in crime in helping community medicine reach the clients that we most want to serve. So now that you know who we are, we'd like to get a feel for who is in the room. And so I know this is the manager track, so that's my first clue. But beyond that, who is in spay-neuter clinics? Oh, a few of you, not that many. And what about municipal shelters? Municipal shelters, a lot more. And what about private or nonprofit sheltering? Ah, yes, cool. And is everybody, who is in like supervisor, manager level or above? Okay, so the majority of you are in supervisor level of above positions. If you're not, you're super welcome. It's good to know sort of who we're speaking to. And the next question for you is, how many of you are considering providing, or well, actually, let me back up. Who is currently providing services to the public that are veterinary services, spay, neuter, vaccines, anything like that? Wow, lots of you. Okay, that's awesome. And who's sort of on, considering expanding, opening their doors? Great, great, great. And maybe going outside of your shelter, working with the community. So just to kind of set the stage for where we are today and sort of what is driving some of the need that you're probably seeing out there in your communities for affordable vet care. So I know graphs are a terrible idea when you have a room that's 100 feet deep, but what this graph, you can probably see the lines all the way from the back, fuzzy, but sorta. What this graph shows that in the past 40 years, what is going on in income inequality. So you've probably heard in the news or you heard on the radio people say income inequality has actually intensified over recent decades. And this is what they mean by that. So the top line is the top 1% of earners. And all the way back at the edge of the graph is 1962. So this is 1962 to 2014. And in 1962, you can see the difference between the top 1% and the bottom 50% collectively of income earners in the United States wasn't that far apart. It's a significant gap, but it doesn't look that far apart. And then you can see through the decades, these are increments of 5 years going up to 2014. When you adjust for inflation, the bottom 50% of earners have stayed flat. And the top 1% is all the way up at 1.3 million and some change, while the bottom 50% is at 16,000. And one other point to make about that is that people who are in that bottom 50%, that's not a stagnant, permanent place for people. This study that I looked at when researching this talk, what this study made the point was that people move up and down the income ladder. Life circumstances make it so that people move in and out of there. So maybe going back to school, getting a divorce, loss of a job, death of a loved one, things like that happen that really impact someone's income and earning potential. And so it's just your sort of public service reminder that if someone comes to you that doesn't appear based on what they're driving, what they're wearing, if they don't appear that they need low-income veterinary care or subsidized spay neuter, you really can't judge a book by its cover when it comes to income, because there's so many things that move people up and down that scale. So related to that, and actually compounding that, is this other graph, the cost of vet care. And what this is from a study called Is American Pet Healthcare Uniquely Inefficient? But this graph was actually in The Economist magazine I think it's from 2016, yeah, it's from 2016. And what this shows is real spending per household just from 1996 up to 2012. And this graph sort of blew my mind a little bit, because what it shows is that spending on vet care is actually outpacing what people are spending on their own human health care and other items like entertainment and housing. So the cost of vet care is outpacing or matching all of those other categories of spending for people in households. And one of the things that is driving this, obviously, as you probably already know, is the incredible advances in veterinary care and the treatments that are available and what's being taught in vet schools today, and the cost of equipment and training associated with those treatments is really driving up what the norm is and treatment and what the standards are for treatment for pets. And as I was researching this, I came across something I'd never seen before. There's an industry term, it's called the stop treatment point, and it's tracked in the vet care industry. And the most recent number I could find was from 2012, but the stop treatment point in 2012 was $1,704. And that means that's the average point where people will stop treating a condition or an illness that their pet has before they have to make a different decision. And that stop treatment point that was $1,704 in 2012, and I'm confident it's significantly higher than that based on the trajectory that it was on. Just in 1997, so 15 years prior, it was only $576. And for those of you math whizzes, you already know that's triple. The stop treatment point has tripled in 15 years. So the expectations of what people will spend to treat an animal has tripled in 15 years. More than tripled since the point that the survey was last published. The results of the survey were last published in the industry. So we're going to talk more about euthanasia a little bit later, but keep that in your mind as we're going through this discussion. The other research I want to call your attention to is a book that really changed the way I viewed our clients living in poverty with their pets. And it's a book called Scarcity, The New Science of Having Less and How It Defines Our Lives. And these two researchers, I think from MIT, these two researchers, first the question was, do poor people just act differently and that makes them poor? And they stay in poverty because of the way something about them is keeping them in poverty. That people in poverty are different somehow, and that's why they're in poverty, where that 1%, they're special in some way, and so their income has gone up like that over the years, while people living in poverty have stayed the same. And so they really wanted to find out the answer to that question, and they studied, and they pulled a lot of studies that had already been done that were being used for other purposes and analyzed data, and they also looked at some of their own studies, and what they found was that scarcity in a bunch of different ways cause some of the identical psychological impacts. So scarcity of time, when you're too busy and you don't have time to meet all of the demands that are on you. Scarcity of calories, so when you're on a diet. And scarcity of companionship or loneliness, scarcity of social interaction. All of these things have a similar effect on people. And people actually perform worse on cognitive tests when they're experiencing scarcity. And the thing is that being busy, being on a diet, and being lonely, there's a fix for that, right? You can eat that donut like I did at 5:30 this morning. You can call your mom, you know, or you can call that friend and schedule time to get together. You can't take a break from poverty. Persistent poverty is a chronic state, and that makes it a special form of scarcity that impacts our clients pretty substantially. So what these two really set out to demonstrate was that it's actually not the person, but the circumstances that they're in takes up so much bandwidth that that is impacting severely some of the other parts of their lives. And if you think about being on a diet and sitting at your desk and thinking, you know, what are you thinking about when you're on a diet and you're hungry and you're sitting at your desk? The vending machine, Cheetos, exactly. So what they assert, as I alluded to, is that scarcity uses a lot of energy and other things suffer as a result. And so they were looking back at all these studies that said that the poor have a lower adherence to their own medication, human medication regimens. This is tracked in hospitals, and they're constantly trying to figure out how to get people to stick to their medications. And poor people perform less well on that. Poor people also perform less well on parenting assessments, whether it's patience, the tendency to reach out and smack a child versus time out or some of the other less harsh punishments. You know, attendance at soccer games and things like that. They, in general, parenting, the poor perform less well. And these guys contend that it has everything to do with that they're chronically experiencing scarcity, and it takes up so much of their emotional and psychological bandwidth that it actually impacts many aspects of their lives that you might not expect. And just like us, people living in poverty are susceptible to impulse purchases and other, you know, self-defeating behaviors and decisions. So if you think about retail therapy, and that, you know, many of us will look to retail therapy when we're stressed out and want to go spend money or buy something, or you might make some impulse purchase that wasn't smart when you're stressed out at the grocery store. The consequences are much, much greater to someone living in poverty when they engage in those self-defeating behaviors and they make those poor decisions. And if you think about payday loans, along with that line of income inequality, payday loans have exploded in the country. There's online payday loans now that have replaced a lot of the brick and mortar payday loan business that was happening, and it's like tripled. In recent years, to where the online payday loans matches the amount that's being done in brick and mortar. And a payday loan, if you're not familiar with it, is, you know, when you're in a crunch, you can't borrow money from relatives, you can't borrow money from friends. Maybe you have a car repair that's unexpected. Maybe you have some sort of, you know, emergency expense that comes up. You borrow this money against your paycheck. You have really high interest rates on the payback, and you end up even worse off. You know, you sort of start the following month already in a hole. And this is a common, you know, had they not taken out that payday loan, they would certainly be better off. But when you're in that situation, that's what payday loans are for. They're for filling that gap that scarcity creates, and the penalty is great for those payday loans. And one thing that's interesting that I forgot to mention on the last slide is that what the two researchers found, they did this study in a mall and they introduced a fake scenario of scarcity. So they pretended they were doing a survey for another reason. So keep that in mind when you're doing a mall survey, that you're being tricked. Whatever they're asking you is not really what they're asking you. But they were doing a mall survey, and when they introduced the idea of an unexpected car repair, and they asked the person on the survey, what would you do if you had a car repair that was $2,000? You need your car to get to work, what would you do if tomorrow that happened? And they had, multiple choice or whatever. And then the people went out, were let out into the lobby, and there was a big table in the waiting lobby where the folks were waiting, and on one end of the table was all these sugary things that were bad for you, and on the other end of the table was like fruit and veggie snacks, and people who had experienced scarcity almost like 40% more often would reach for something that was bad for them and make these just these little decisions, even when the scarcity that was introduced was hypothetical. So how can we counter the effects of scarcity? One of the grim realities of what we do is that at the ASPCA, and for some of you, we're a charity and we have a specific mission, and we're unable to solve poverty, and therefore we're unable to eliminate scarcity from our clients' lives and from the public who you serve if you're in a municipal shelter and people are coming to you relinquishing pets. Or coming to you and needing financial assistance for medical treatments, or else they have to relinquish their pets. So you're not going to be able to solve the thing that brought them to you in the first place. However, we can look at our own policies and procedures and see if perhaps we're inadvertently creating barriers for our clients to be able, or for the community that we serve, to be able to take advantage of our services. And one thing is, many of our clients don't operate by an Outlook calendar. Most of our clients have non-traditional, they don't have office jobs where they sit at a desk and they have an Outlook calendar and it's filled with appointments. Many of our clients work multiple jobs at different hours of the day, and it can be challenging when you make an appointment for them that's 2 or 3 weeks out for them to be able to predict what's going to be happening the night before that appointment or the day of that appointment. And so we have moved to text reminders to try to help people make their appointments. So text reminders maybe a few days before and then maybe the day before. And we don't call because we found that a lot of our clients won't pick up if they see a phone number that they don't recognize. They don't have the minutes to be able to mess around with a sales call. And they might completely run out of prepaid minutes if they have a prepaid phone. And so texting is the only way that they actually can communicate. Because if you try to call, it'll give you a message that says, this phone is temporarily out of service or whatever. And we know that for our clients, that means that they don't have any minutes that are prepaid available on their phone. So the other thing about sort of these reminders and around reminders and appointments is that, we discovered not too long ago that some of our staff out in our LA clinics were we had implemented their own 2 strikes you're out policy. So if you no-showed for 2 appointments, they weren't going to make you another one. You just can't participate in our services. And that's on our primary pet care clinics, which is, we can talk a little bit more about later, but it's basic vet care. It's not spay neuter. It's wellness plus some basic non-invasive veterinary medical care. And, so that policy, knowing that our clients experience scarcity, knowing that for some of our clients, there's a lot of things that can happen between the time they make that appointment and the morning that they're supposed to get all their stuff together and their pet in to see you. And so if those policies are putting out barriers for your clients, how flexible are you able to be? How much can you sort of overbook to compensate for some of the no-shows so that you can be there when the client needs you? And the other thing is price. So whether you're offering spay-neuter or wellness or vaccines or anything like that, people living in poverty will it'll matter if the surgery costs $80 or $120. It matters to them. And if there's things like plus $30 for cryptorchid, plus $50 for pregnant, bands for different weight groups of dogs. So this size dog is this much and that size dog is that much. I always underestimate the weight of my dog because I'm certain that she's perfectly fit and within the weight that I'm expecting her to be. So I really, at any given time, I don't know why most of our clients would know how much their dog weighs, but if you have those kinds of policies where they have to worry that they might get there in the morning and you're not going to take them, or they are going to come in the afternoon to pick up their animal after surgery's done and you're not going to give it back because they don't have the extra $50 or $75, that could be inadvertently keeping people from seeking assistance in the first place. So when we've worked with groups in the past, I always look at their price lists to see if they match up with the type of client that they're most wanting to serve. And if you're serving middle-class clients, some of those add-on charges are not a big deal. But if you're really trying to serve that neediest part of your community, those kinds of things really matter. Unexpected charges are a big deal to them. And then transportation, very few organizations can handle transportation, but we have known even small shoestring organizations with only 1 or 2 staff that actually have volunteer providing transport. It's complicated, there's risks associated with it, I'm not saying there's not, but it's something to consider as a barrier. Especially if you're a stationary clinic and the clients that you're trying to serve most, maybe the animals, where a lot of the animals are coming from that are coming into your shelter might not be close to your shelter. And there might be pockets of the community that can't afford the gas money or maybe they don't have access to vehicles at all to get to you. And so you really do have to at least consider that barrier and see what things you can do to overcome it. So with that, I'm going to turn it over to the little square.
Okay, hey everybody. So once you've made the commitment that you're going to be providing services to people living in poverty or in underserved communities, you have to start making the hard choices about what your program is going to look like. And the first things you probably want to ask yourself is, who do you serve and what services will you provide? And before I get further into it, these questions and a few other questions on the next slides are being presented in sequence as if you think about them one, then the other, when in reality, you have to think about a lot of different things at the same time to design your program. And we'll come back to that idea in a couple of minutes. So again, who do you serve and what services will you provide? And generally, the more narrowly you provide services, the more narrowly you define who your client is, the deeper your services are. And the converse is true. The more broadly within the community that you provide, that you define who your client and your patient is, the fewer services or the less deep your services can be. And both of these models, whether you have a very narrow slice of clients that you provide a lot of services for, or whether you have a broad group of clients that you provide limited services for, both of these models are totally valid. And the communities that we work in general, are so in need of services that they need everything. So some of this decision is really about the philosophy of your organization. And if we think about this in terms of human health and healthcare for children, there are organizations like St. Jude's Hospital or Shriners Children's Hospital that serve a very narrow slice of children who need healthcare. But for those children that they serve, they provide a vast array of resources and services. On the other hand, there are organizations that provide vaccinations and nutritional support for children, and they provide a very limited number of services, but to many, many more children within a community in the hopes of raising the overall welfare of the community rather than deeply affecting a smaller number of children. And so both of these models are valid, and you just have to think about how do you want to serve your community. Next slide, please. Jocelyn just alluded a little while ago as to how difficult it can be for people living in poverty in the areas that we're striving to reach to be able to afford veterinary care. And another thing you have to consider is, what is your program's financial model going to be? Are you going to be focusing on people that can afford to pay something for care, but maybe not what a general practice would charge? Or are you really targeting people who can afford very little or nothing to provide care for their pets? If you're serving that community, your services will need to be fully or partially subsidized, which means you'll need fundraising, donations, grants in order to support your program. There are other programs whose goal is to break even. So services cost less, but support the clinic. And many organizations find that this is a much more sustainable way to be able to fund their program. But it means that you won't be able to serve those that are most in need of your services, who may not be able to afford to pay very much or anything. Another model that some clinics run is to actually turn a profit. And the way that's done is to run for each transaction on a very low profit margin, and to actually turn a profit by doing volume of work. So many clients seen rapidly, with each of them having a small profit built into the fees. And again, that is a totally valid model to run a clinic on, but it means that you're thinking about serving a different population. Next slide. When you're thinking about your clinic and what you want to provide, in addition to what you would like to do, at the same time, you have to be considering what are the resources that you have available. And money, of course, finances is the big resource that is in most demand and in short supply. And being well funded, whether that's through fees that you charge, donations, grants, can certainly cover up a lot of other issues that happen in a clinic. But money alone doesn't solve all of the resource problems that you might have. Finding people to work in the clinic, staff, particularly medical staff, veterinarians, and technicians, are in high demand for all practices. And although this might be your true calling to serve underserved communities, to provide these kinds of services, it's only a small segment of the professionals who are drawn to this type of work. And so you might be limited in what services you can supply and how many services you can offer based on your ability to staff your clinic. Another resource that might be in short demand is space. You might be working in a space or a clinic or set up something in a space that was not specifically designed for what you want to provide right now. So if you run a spay neuter clinic right now, if you have a shelter medical clinic and you'd like to start providing these services, your space, the different rooms, the size of the waiting area may not be what you would ideally design if you were specifically designing a space for this type of program. And so you may have to flex and bend on what you can provide and how you provide it based on that space that you have. And of course, time is another resource. When are you able to provide these services? Is it only after shelter hours in the evenings or on the weekends? Or are you running a spay neuter clinic and you'd like to have a few hours of services being provided between intake and discharge. So as you can see, all of these types of resources also have to be considered when you're thinking about what your program is going to look like. Next slide, please. And so this is my way of saying you have to think about all of it at once. You have to concurrently think about the parameters of your program, who you're going to serve, what services you'd like to be able to provide, where you'll be doing it, who you have to staff it, and figure out how all those pieces come together to design a program. And because every organization and every clinic has slightly different philosophies, slightly different resources, slightly different staffing available to them, every program is going to look slightly different. And that's absolutely fine. The communities that we work in are so in need of this type of service that there's no right and wrong as to what we provide. Whatever is provided is needed. So next slide, please. In general, the ASPCA, which as many of you know is a fairly well-resourced organization, even the ASPCA cannot provide all things to all people, and we have to make these kinds of choices too. And we have, in general, decided to go with a broader, serving a broader slice of the community and providing limited services rather than providing those deep resources to single or individual clients and pets. And our goal is to raise the overall welfare of the animals living in the communities that we serve rather than to really deeply affect a much smaller number of animals. And again, which way you go is up to you and your organization. This is just how we have decided to tailor our resources and our programs. Next slide. So when we have a program, when we talk about designing a program that is trying to figure out how much we'll subsidize of services and what the price point will be, and we're thinking about what services we'll provide, how limited will they be, it starts to feel, even though it may not be true in reality, that the clinic and the medical team that's advising the client starts to feel more involved and part of the decision-making process for what care that animal receives. So in a general practice, in a normal middle or upper middle class area, you know, the veterinarians and the medical team provide information and they make recommendations. They talk about prognosis and cost, and they may offer referral to a specialist if it's appropriate for that patient. And then the veterinarian and the medical team kind of steps back and turns that decision over to the owner as to whether they move forward with the recommendations or go to a specialist. And we don't feel responsible for that decision, right? That owner is making that decision. And even if that decision is based in part or totally on cost and some other issues that might affect owners similarly in underserved communities, we don't feel responsible for that decision for that owner. On the other hand, when we're working with owners that we know have very limited access to services, we might be the only clinic that they are able to either afford or sometimes to physically access. You know, sometimes people will ask me, you know, do we get a lot of resentment from veterinarians who have practices in the communities in which we work that we're going in and providing subsidized services? And a lot of times the answer is, if you're choosing the right communities, there probably aren't veterinarians already practicing there. So our clients have really limited access. And because we know the pinch that our clients are in, and we're putting limitations on what we will provide and what the cost will be, it often starts to feel to the veterinarian and the medical team as though they have become part of the decision-making process and they have a say in the course of treatment and the outcome, even though ultimately, just as in another practice, the choice is up to the owner. The veterinarian in the practice feels as though they have more say in that decision. Next slide. And this can start to really weigh on our staff. And so I wanted to talk for a couple of minutes about the difference between empathy and compassion and how we should address these with our staff. So the staff that chooses to work in these types of practices are generally incredibly empathetic and caring people. They're there because they want to help. They're there because they want to serve. They want to give back to the community. And so their initial instinct, what they would really like to do in a perfect world, is provide all services and everything needed for the client and the patient in front of them, because they can feel what that client feels. They can understand, they can relate, they want to assuage the hurt that that client and that pet are feeling. And so that is the first instinct of our teams. And what we have to do is ask them to take a step back from their empathy and be a little bit more objective and to feel compassion rather than empathy. So when we step back out of the mindset of our clients, we can see the bigger picture, and we can see and understand that if we put all of our resources into the animal and client in front of us that we really, really want to help, if we help them, then we may never meet the other 10 clients and their pets that need our help too. And we might not be really, because we want to help so much in the moment, we might not be really doing as much good for the community and helping as many pets as is possible. And so this is really hard for our teams. It's hard when there's someone in front of you that you really want to help, but you need to be able to take that objective step backwards and really have a bigger picture about who our program serves and what we can provide and why we make those decisions. So next slide, please. So when we're doing this, a lot of the terminology, a lot of the syndromes that we have identified in caregivers are first identified in nurses in the human medical field. They are on the front line of providing care. They are the empathetic, want to help everyone, people in human health care. And a syndrome was identified within nurses, and it applies to veterinary professionals as well, called moral distress. And moral distress is that visceral response that a health professional feels when they're in a situation where what they need to do based on protocols, based on what's best for the community as a whole, based what's best for other patients that might come to them, is not best for what is the patient that is in front of them right now. So there's a conflict between what's best for this patient and what's best for the community as a whole. And this visceral reaction, this stress really weighs on people. And a lot of the remedies for it are very similar to the kinds of self-care remedies that are recommended for compassion fatigue. And I know that there's a lot of information and presentations on compassion fatigue, and I am not an expert on self-care. So I will skip over trying to address that. However, next slide, please. We will talk for a second on how we might mitigate some of that moral distress in our teams and help our clients. And the two things that we can do is, with our team, be really clear about what the protocols are, what we provide and what we don't provide, and why. Why do we provide certain things? What is the basis of that? Is it based on data about prognoses, about resources, about outcomes, and how have we made these decisions, and to remind our teams periodically why we've made that decision. And even if it's hard in the moment, to have them at least have the knowledge about why, for the overall welfare of the community, that might be the best decision. The other thing we can do with our clients is set expectations. And when I say that, what I mean is, as soon as clients come to us, as soon as their pets have some kind of medical condition, we need to let our clients know that there are some services that we can provide and some that we can't. And we also need to let our clients know that we might start on the path of treating their pet. We might need to do some diagnostic work. But based on the results of those diagnoses, we might need to tell them we've gone as far as we can go and we can no longer help with that. And even if the client is upset in the moment, having set the table that this time may come may help in dealing with that situation when it arises. Next slide. So I wanted to talk just for a second about what we may find when we start serving underserved communities. And at the ASPCA a few years ago, when we started to really provide care in our first underserved community, which is an area of the Bronx that has a lot of systemic and generational poverty, what we thought was that we might see pets that have lower body condition scores, like skinny little pets. And we didn't find that at all. We found that the pets were happy and chubby and loved just like in any other practice. We also thought maybe we'd see some different kinds of medical conditions that we'd have to treat. And the truth is, we do a lot of preventive care. We treat a lot of ear infections, upper respiratory infections, conjunctivitis, urinary tract infections, all the same things that one would commonly treat in any practice across the country. We thought that maybe we'd see an increased rate of possible neglect cases or cruelty cases, and that never happened. While we do occasionally see an occasional suspect of cruelty or neglect, it's not out of line with what one might see in any other practice. Click, please. The one place where we did see some difference and some increase in services from a general practice was that we do in some cases see an increased rate of humane euthanasia. And that is either because owners have not had access to care, and so they've come to us for care when their pet is really far along in the stages of disease, or because that stop treatment dollar number that Jocelyn spoke about at the beginning is much lower for our clients. And so they do often need to make that decision about humane euthanasia at a different place in the course of disease than some other clients may need to. Next slide. So I wanted to just take a minute and actually talk about humane euthanasia. We want to, of course, when we're helping a client to make this decision, give medical information and treatment options. And even if ultimately the decision is humane euthanasia, we are giving the client something by giving them that information and allowing them to talk out what their options are. And a lot of clients will really, truly value that information. And owners in all walks of life may consider things other than the physical condition, the medical condition, or prognosis of that pet. They may consider the ability to physically care for the pet. If it's a large dog and it's an older owner who's not able to physically help that pet get up or move, that might affect their ability to care for the pet. The ability to administer medication, we all think about this in terms of, well, if someone has to give injections, they might not be comfortable. But there are some pets and some owners for whom giving pills, I mean, some cats it's really difficult. And so that may go into the decision. The need for additional visits. Can the client take off from work if they need to come back periodically for visits? Can they get transportation to your clinic? The quality of life of the patient, and the owner may define that differently than you do. If the owner thinks that it's been a great joy to this pet's life to go on very long walks every day, and the pet is no longer able to walk, the owner may perceive that as a big drop in the quality of life for that patient, even though they're medically stable. And of course, the cost of care. And when clients ultimately make that decision, I used to think when I first became a veterinarian that I could decide whether an owner's decision was right or wrong about euthanasia, and that they needed to make the same decision that I would have made if I were in that position. And with more experience and meeting more people and knowing more about their situations, you learn that every decision for the owner and their family and that pet is individual. And the decision to pursue humane euthanasia has to just be reasonable in that situation and not what you would want to do for your own pet. And of course, the most important thing once the decision is made is to provide support and to communicate well with the client. And I'm going to turn it back to Jocelyn for more information on that.
All right, so we've talked like really big picture global economics. We've talked about, different practices and having SOPs and procedures to help guide the work that you might be embarking on. And we would be remiss if we didn't talk about the actual client and the relationship that you have with the client. And so, one of the most wonderful things about being able to provide care for people's pets, whatever level it is that you're doing, is you get to see firsthand that bond between people and their animals, and you get to be the hero and the helper, and that's really awesome. And I'm sure you've heard this before, but the people you have doing this work is really important. You want to hire people who really want to serve. I've always been a person who really enjoys serving. I've always enjoyed providing that great experience for customers in a variety of industries that I've worked in. It's just fun. And being able to do it for people's animals is ultimately cool. So I think hiring people who want to do that is important. And it's really funny because Bonnie had this exact thing in her presentation yesterday. And it's just, smiling, having people who smile, the people who answer the phone smiling, because you can hear that through the phone. You can always connect with people through their pet. Use people's names, introduce, the veterinarian and the staff should introduce themselves whenever it's appropriate. Be really genuine and check your judgments. As Brown mentioned, humane euthanasia, as an animal welfare movement, we've gotten more away from, well, if you can't afford the medical care for your pet, we'll go ahead and take it and adopt it out to someone who can. Or we're going to provide the medical care, pay all that money, and then give your pet to somebody else. And we've really tried to get away from that. And if a pet already has a loving home and they just need a helping hand, providing that helping hand and letting that pet stay in the home is becoming a lot more common, thankfully, than the alternative. And then the power of being nice when you can't do everything, being kind. People are going to be so happy for whatever help you can provide, and so often all that is information about what's going on with their pet and what their options are. So questions that build trust, I think a lot of times we like to just fact storm people when they come in. We know so much about the topic of animal care, and we tend to ask brief, closed-ended questions and move on. And really building trust with people by asking open-ended questions. So instead of any diarrhea, that's how have her stools been lately. Instead of are you able to give insulin injections at home, that has sort of a presumptive, air to it. This came from Dr. Garrett, who came and gave a talk. She's the head of oncology at the vet school at the University of Illinois, and she's amazing, and she does, she has a lot of difficult decisions, or a lot of difficult discussions with owners as an oncologist, and she uses, on a scale of 1 to 10, how likely is it that you can give your cat an insulin injection twice a day for the rest of her life? And you might add to that and pay for insulin. So closed-ended questions discourage elaboration and limit that sharing from your client. They might be keeping something back because they think you're going to judge them, or they think they should know something that they don't know. And open-ended questions really encourage that elaboration and telling of the story. And then compassion statements. Dr. Garrett explained that I'm sorry is not a compassion statement, and neither is I know how you feel. Because the fact is, you can't really say that to anyone about anything, right? Listening to their story and not just the facts is going to help you build that bridge with clients when caring for their pet. You become a trusted partner in that, and you can say things a little bit differently, like, I can only imagine, or that must be really hard, if they tell you that, their Mastiff can no longer go up and down the steps of their walk-up because he's 9 and his legs are just giving out. You don't know how they feel, but you can say that must be really hard for you. Or it sounds like you've had a really tough time with that. Or I can tell how much you care about each other. Those kinds of things really, connect you with that person as a person, and not just as the next client, particularly if you're in a high volume environment. And avoid the butt sandwich. So this was so hard. Dr. Garrett led our doctors and medical staff through some practice scenarios of this, and this was incredibly difficult. So there was the dog in the scenario had bone cancer, and the leg had to be amputated. And it was so hard for the doctor in my group to not say, yeah, but, it's going to be great. The pet's really, he's going to do great. So instead of saying it might be hard to imagine, but she's going to be fine on 3 legs, you can say things like, I can tell you're concerned about amputation. In my experience, dogs adapt beautifully to life on 3 legs. And in cases of, if you're going to be providing any type of community medicine, you might not even get to hit by cars and fractures with your budget and your scope of your program. But chances are you're not going to be doing orthopedics. You're going to be doing amputations, right? So acknowledge where they are right now rather than trying to fact them out of it. And just something as simple as offering a tissue. If you're not a hugger and you're not a back patter or whatever, and you don't like touching people, that's totally fine. Have a box of Kleenex in every room. And when it feels right, you can invite them to share, what are your thoughts about this? But try to resist the urge to just keep talking, because either you're uncomfortable or you think it's going to help if you just pile a lot of information on. And then when the news isn't good, do what you can. We don't work in ideal environments. None of us do. But if you can find a quiet location, that would be great. Prepare yourself a little bit and collect yourself and review the information. Make sure, if you can, that you know the pet's name and you know the pet's sex. And you know the client's name whenever possible before you walk in the room to talk to them about it. Or if it's a tech that's going to be going in or whoever's going in, train your staff to prepare this way so that they can give that client a really as soothing an experience as possible. Make eye contact. It's really hard to deliver bad news, but you got to buck up and do it. And it's not a good time to make a mistake, but if you do, just apologize. And avoid lengthy buildups when you're delivering bad news. A simple warning shot is fine. You can say something like, unfortunately, this is not something that we're going to be able to treat. Things like that can sort of brace the person for what they're about to hear prior to delivery. And then on the receiving end of bad news, the client might be unable to think clearly right after you deliver bad news. Their emotions, their response or their reaction might not be what you would expect. It might be that they seem cold and like they just don't care very much. We had this recently on a primary pet care clinic, and it became a really big deal because the staff was very freaked out about how nonchalant this guy seemed about his dog who had a tumor coming out of the side of his head as big as an orange. And he seemed like he just didn't really care. He was coming in for humane euthanasia, and it caused a big kerfuffle. The staff was really upset by that. But the thing is that you know, he was a big, burly guy coming to our clinic in LA for help. He obviously knew that this was something that should have been dealt with much earlier, and his reaction might not be what you think it's going to be when someone's euthanizing their 14-year-old or 15-year-old pet that they've had its whole life. And they might be speechless and not be able to say anything. If the reaction surprises you or it doesn't match the news that you delivered, Dr. Garrett recommended asking something like, is this different than what you expected? Because maybe they heard you wrong, maybe the information didn't translate, or they didn't understand the terminology that you used. And you don't need to fill the silence. That's, you know, you don't need to keep talking. If someone's not ready to speak when they get tough news, you don't have to do it for them. I turn it back over to Brown.
So in the last 2 minutes, we just wanted to summarize some of the key takeaways that we hope you will leave this presentation with. And the first one is, just because you can't do everything doesn't mean you're doing nothing. Providing information and support to owners and patients is really important. The best course of treatment is different for each patient and owner. There are lots of individual considerations to take into account when making a decision about, when an owner is making a decision about health care for their pet. And the most invasive and advanced course of treatment isn't always in the patient's best interest. That's something that we as medical professionals sometimes lose track of. I used to always say to people when they would feel bad about not being able to afford a certain treatment, I used to say sometimes, all because we can do something doesn't mean we should, so let's step back and think about what's really best for your pet. Ending suffering is doing something, and communicating effectively is everything to our clients.
Any questions for Dr. Brown or me? Yes.
In terms of when you get to that appointment and the person turns to you and asks, what would you do if this was your pet? Mm-hmm. How do you approach that? Do you actually, as a veterinarian, do you approach it as, this is what I think is the best course of action, or this is what I think is the best course of action for you?
That's a good question. The question is, what would you do if the client asks what you would do if it were your pet? And I'm going to let the doctor take that one.
Yeah, so that's a really interesting question, because that's something that veterinarians get asked in every practice. That is a universal question, regardless of whether you're in an underserved community or in a really posh upscale hospital. And all I can tell you is what I say to people when they ask me. I generally say, I am in a very different situation than you are in, and my decision should not be your decision. You know, I am able sometimes to bring my pet to work with me all day. I have access to lots of care. I have certain advantages in being able to provide health care that to give an injection, not a big deal for me. Maybe it is a big deal for you. And so I really try to just take myself out of it and say that, you know, what is right for me and my pet is not what would be right for you and your pet, and really try to go back to what would work for them in that situation.
Great. Any other questions? We'll be up here to answer questions if there's any more questions. And a huge round of applause to the IT team for dealing with our wacky situation. Thank you guys so much. Have a wonderful rest of your conference.